spot. Um, so DMC was extremely helpful on the beginning of my journey, because the Anand Medical College itself is very USMLE oriented. All my peers, all my seniors, everybody knew about USMLE from the beginning of my batch. I was in 2014 batch, and I graduated somewhere in 2020. And and everybody was on this journey, and it was an environment where we had information that was not secured or limited to a point. Everybody was very, very willing to share it with their friends and let them know that, these are the NBMEs that you have to go through. This is the procedure, go through Kaplan, you do UWorld, and, do these many rounds of UWorld, do first aid and all of those things. So like everybody else here, like IM applicants, FM applicants, I'm from India, so we don't have a separate EM specialty, subspecialty in India.
True.
If you know it here. So I started my USMLE journey thinking I'm going to be an IM applicant, and that I'm going to be applying in internal medicine. It is a norm, right? An IMG starting out from a country that is underdeveloped, somewhere far off, starting the journey to the United States, they decide that, let's take the easier path, because it's a very high IMG acceptance rate. That is what they say. But when you get into the match, you realize it's not true. So everything takes a lot of hard work. So that is where I started, and I started studying for my step 1. I think so. I was kind of a wildcat during my college years. I had my fun. I enjoyed myself. I only used to study for my professional exams, like my profs at the end of the year. And I was never one of those studious kids, never at the top 5 of the university positions. I've never gotten a distinction. So yes, I'm hope to everybody in this class.
Same.
So yeah, and I would always look at these kids and just think that how do they do this? What does it take to reach the top? And I'd always kind of envy them in their way. Somewhere along the line, I found the sheer strength to just keep going, and I started studying for my USMLE step 1 examination somewhere in my intern year. Now I wasn't a poor student, so I'll let you guys know that I was average. Okay, I was doing well. I was passing with good colors, if not flying. And so I took my step 1. My step 1, I think I started internship and took a break for like people usually take extensions in DMC. And it has a norm. It has this procedure where you have to go through this application process, and then you get an extension for a period of 4 to 5 months, where you tell them that you're going for outside externships, but you can use that time to study for your step. And that is what I did. I used that time to study for my USMLE while I was working at I think it was the starting of COVID. I was working at one of these centers which was open to COVID patients. So I started side by side, and by Babaji's grace, I did really well in my step 1. My step 1 score was 255, and I did not expect myself to do that good. And I after that point, I was kind of losing faith. I was like, how did I do well? Like, how is
Talk
this
about self-doubt.
Talk about imposter syndrome at its peak, because you just assume you're not worthy enough. We are growing up with so much doubt. Hi, Hansini, I see you there. Nice to have her here. So you grow up with so much doubt that you just, there's not a single bone in your body that tells you that you're worth it. But in the end, the amount of hard work is directly proportional to the end result of what you get. And yeah, my step 1 score, it made me very proud. I was very happy with it. Then I went ahead and I started my internship again. While I was preparing for that, I took my step 2. Simultaneously, I started doing my master's in health administration. But till this time, I was not sure about what I wanted. I was choosing IM because norm, easier, everybody does it. It's what goes into an IMG's brain when they're just starting out their journey, until they have their prior goals, that I have a few friends who are keen on psychiatry because that's what they've grown up with. They just like the idea of being a psychiatrist. And that wasn't the case for me. I was just into whatever I get. Um, and during my step 2 preparation and my master's in health administration, I came to the US on a student visa. And I took my step 2 here. And I was also simultaneously doing rotations at the center that you mentioned previously in New Jersey. The director there was an emergency medicine physician. And he talked to me for a few minutes while I was on my IM rotation. And he said, you have a personality that I think will suit EM more than I am. And it kind of stuck with me. I'm like, wait, is there something called, like, what is EM? Like emergency medicine, is that different? I thought it was, I was very confused. So I did my research. And then I reached out to that director. I reached out to him. I was like, okay, so well, you put this thing in my brain that I am this personality for EM, and now I cannot stop thinking about it. So you better, get me into some rotation or something that I can get experience out of it, because I wanted to know. By that time, I had realized, I guess it's the growth that takes place. It's a growing curve. I realized that IM was not my cup of tea. Lots of respect to my hospitalist friends. I do not have family in IM, but I have friends in IM who just, they're very hardworking and they do a lot of thinking. And I, in that moment, while I was doing my rotations there, I figured that this is not the thing I will be happy doing for the rest of my life, which is when I reached out to them. They were kind enough to offer me a rotation in the hospital. So that is the first point. I got a lot of questions. Networking, reaching out, get out of your comfort zone. If you want emergency medicine, it's for outspoken people. It's for people who are ready to have what they want in that moment. You need to reach out. You need to network. If you're an introvert and you're trying to get into emergency medicine, yeah, it might work. It definitely could. I mean, I don't know, but it would be very helpful for you to just get out there and let people know that, okay, this is what I want. This is my mindset. So I networked, and that is where I got my EM rotation. And I was mind blown by how in love with the specialty I fell. The procedures, everything that they were doing on the spot, being hands-on. I just found my calling during that time. And I didn't have that was the time that I was preparing my personal statement as well. So I didn't go through any companies or anybody helping you to write your own personal statement or something, or reviewing it. And in that moment, I think having all of that going on at once, I realized that the only thing that will get me through here in a very competitive specialty is just being myself, is just making sure that I have a very aggressive and competitive personality. And I wanted to depict that in my personal statement. And that is when I started working on it as well. One after the other rotation, I reached out to somebody in Michigan, New Jersey. I traveled to Michigan. And then after that, I found a third rotation in Oregon. I did that as well. All of these rotations, I got an LOR and I got a supplementary letter of evaluation. So one of these rotations was hands-on. The other two were observerships. So you have to note that down. They still managed to give me an SLOE, which was very kind of them, because they saw my sheer passion for the specialty and they realized that, okay, this girl actually genuinely fits into the criteria of being an EM physician. And they helped me out through it, because people are helpful. Nobody's going to take away what you want from you. Because they're mean people. Everybody's here helping you. Everybody's kind enough to extend, these little things that could genuinely change your journey in the future. And that is how I got my 3 LORs, my SLOEs. And I knew that even though I had the scores, I had the LORs, I had the SLOE, but I was lacking something. I was an IMG. It's always seen as that red flag. Oh, she's an IMG. She doesn't, and in more than the people who were going to interview me, or people who were going to judge me for being an IMG. I was judging myself for being an IMG. I was like, oh, these people have grown up in this environment. They've done central lines. They've intubated patients. They've been catheterizing patients since med school. What have I done? I wasn't very hands-on in med school. That is when I went back to India, and I got this. I did an ICU rotation for 2 months in one of these hospitals in Jalandhar city, if anybody here is from Punjab. And I practically, all the procedures that the nurses were doing, I took it out of their hands. IV lines, I was like, okay, let me do it, because I wanted to make sure that I was ready to be in this specialty that is going to be extremely competitive and hands-on. I did IV lines. I would catheterize patients. I saw intubations that were going on, and the ICU life there, it's going to give you enough experience to tackle that barrier where you feel like, oh, you're lacking behind in the procedural knowledge. After that, I was confident. I was like, okay, this is going to be just fine. Even if I'm an IMG in these past 2 months, I've done enough to just make myself happy with the chances that I'm taking. At least I've done my part. I'm trained, and I've got this, and I am a doctor. And that is when the imposter syndrome, it started fading away a little. After that, yeah, and during that match, of course, I applied to IIM as a backup, because you need a backup coming from a visa requiring position. Yeah, so step scores, my personal statement was very aggressive. And my experience, I did not, take a chance at that. I always made a note that I was verbalizing it, that I am trained. I've seen this, I've done this. And there's a rule: you see one, you do one, and you teach one. That's how EM works. And you see one, you do one, and you teach one. And that is how you train enough for it. And nobody can blame you for being a student. Residency is you being a student, right? So you're still going to be learning when you're a resident. You're an intern. You're supposed to be the bottom of the food chain. You're supposed to be the stupidest. And if you know these things, you're great. And if you have the confidence of learning, and you're eager to find out what you did wrong, you're doing great. And that's when I applied to the math cycle. I applied to about 55 EM programs, and I applied to about, I think, 30 IM programs. I had 7 interviews for internal medicine, and I had 4 interviews for emergency medicine. Somebody asked me in one of the emails that I recently received. And all of my interviews were really good. I did not feel judged in any of those interviews, and all of these facilities were extremely IMG friendly. And the position that I'm presently at is the Lewis Cale Medical Center here in Salem. When I interviewed here, I really vibed with the program director. We were talking through this, online interview, and he goes, well, Ramandeep, I have to say, you're an international medical graduate. We had our doubts, but then when I read your personal statement, I could not relate to anything more. It was like I was writing it. I remember writing phrases like, I thrive in chaos. I did not hide that. I have a tendency to be my best version under pressure. I'm very competitive. I will make sure that I'm doing my best when I'm put in a situation that, that's going to take me through hardships. And somebody's trying to enter. And the things in my personal statement, they were very, I didn't try to hide any part of my personalities. And I made sure that they knew that I was extremely outgoing, that I love singing, and I love going for hikings, and I love to travel, and all of these things. And he mentioned it in that interview, that reading your personal statement, it made me feel like I was writing it, that I was the one who wrote it. And which is why you're on our candidate list. And in that conversation, I asked him that, is it possible for me to come in for an in-person interview? Because I wanted to see what they were working with. Because remember, residency is not just you choosing a program, no matter how unworthy you think you are, or how much you think that you desperately need it. Residency is you choosing a program. it's your home for the next 3 years. You have to make sure that you're in this for, you know, the long haul. If you're not comfortable with the people that you're working with, you'll not be succeeding in the end of the day. And that's what I did. I asked him if I could just come in for taking a look at the program, if I could just meet the faculty. And he was more than welcoming. He's like, yeah, you know, why don't you just, we have the entire month open, so just come in whenever you can. So I did. I flew in here. I met with my faculty here. It was, and when I met them, and I vibed a lot with the faculty that was going to be teaching me, to be talking to your attendings about issues that are in your head instantly without thinking about them first, and making a list and being very, you know, list wise organized. We never did that. I was able to just go up to them and ask them, oh, so this is, you know, I attended a didactic session with you. So didactics is when we have this one day off where we just discuss our cases that were really hard. We'd study on topics that seem to be a little harder to grasp. And we had this topic on CHF. And I remember that one of the residents was giving his presentation. And I after that presentation, I just walked to Dr. Pasternak. He's one of my associate program directors here. And I was like, well, I don't think he did a very good job of covering it. And he's like, well, you know, this is why we really interviewed you, because you're very outspoken. And you're right, he didn't do a very good job of covering it because there's a lot more to cover. And then he goes up, takes the podium, and starts explaining the other reasons that, you know, go by in that presentation and everything else. So, and I knew it instantly. I was like, okay, well, this is going to be my #1 ranking program. I don't want to go anywhere else. This is top tier for me. And I had a lot of fun in my 2 days that I stayed with these people. And yeah, and then I ranked them as my #1, and I matched at my #1 spot. And I'm very happy to be here. And I do not feel underqualified at all. Even as an IMG, I feel like I'm just qualified enough. And I think I will make it. Here's to hoping. So yes, that's how my journey has been so far.
That was very insightful, actually. Through this conversation also, you have demonstrated the strong, fierce, and outspoken personality, as you said, that we can see even in this discussion. So I was going to ask you, what qualities do you think you embody that make you an excellent EM resident? And so you answered it. A few things I would like to ask is, clearly, as I can see, there are no hierarchical barriers in the environment that you are working with, because if you're able to be outspoken in that manner, that is really commendable. Another thing I would like to ask is this networking problem, which this is something that IMG struggle with. Sitting in India, how do we network without any personal contact with our faculty people or people sitting in the US, while we are in India? So can you please shed some light on that?
Yeah, absolutely. So the first thing where you mentioned being outspoken is that you have to remember that EM is probably the only specialty that really values teamwork. So there's no hierarchical, it has to be a lot of psychological safety to work in emergency medicine, because everybody is a team. When you're working on a code, trying to achieve ROSC on a patient, nobody's higher up, nobody's low below. Everybody's just in there to figure that out and have that patient back on the table. So EM is very leveled with that perspective. And I think that is why my personality works here. Otherwise, I would have failed drastically, but thankfully, no. So the second question, the networking part. So remember the medical director that I was telling you about? He's actually, and I mentioned that DMC is very USMLE friendly. That's my medical school. That's my medical college. All our medical colleges are very USMLE oriented at this point, because 40% of our med school students are aspiring USMLE candidates. From what I see, in my case, it was 40 because I belong to that tertiary care center where people came in hoping that they will be going in for USMLE and everything else. So Dr. Gurpreet is actually from DMC, which is how I reached out to him in the first place. He was my medical director in the rotation, and he's the one that I reached out to again for my emergency medicine rotation. So network out to your people. people who have gotten through this journey and have done the same things as you, and people who know the hardships that come across your way, people who know that, well, it is very tough to come from there to here, and this is your way to go. And I promise you that none of the international medical graduates who've come here after so many hardships and after so much struggle, they'll never turn you away. Nobody. And that is number one, because as a physician, you're empathetic, and if you forget that part of your personality, you won't make a good doctor. Right. So and I reached out to everybody. My the other Good Samaritan Hospital in Oregon, I reached out to another one of my DMC seniors who secured me that rotation. And the one in Michigan, I secured by constantly harassing that program with emails. But you got, and as I mentioned, you need to be very focused on what you want. Do not back down thinking that you'll be irritating programs. Yes, that happens once you've applied in the match. Do not be just sending up emails for no reason. Thank you mails, welcome mails, goodbye mails. Nobody reads that. But when you're trying to secure a position, even having a single person look at your application makes a difference. So it'll make a difference if you're sending emails to multiple alumni members from your home colleges. It'll definitely make a difference. And coming to that, I actually have a list of programs. I sat down one day and I went through, there's this, I don't remember the exact name. It's, I think, and this is I have no affiliation with any online website, but I went through this website where you could see the most IMG friendly programs. And I clicked on individual program. I went to the number of residents they have, and I went through the resident list. And when you go through that list, there's like a small spot where there's this column that says what college they're from. Even if I did not know them and they were from Dayanand Medical College, I email them. Hey, I'm from your med school. I'm going through the same journey. Have me. Like, just please let me come in and let me just show you that I'm worthy, and let me just help me secure my position in the same field that you're doing. And that's how I went around with the networking part of it. Also, not to forget that I did my master's in health administration, and a lot of the contacts that I made throughout that journey helped me secure more contacts. Like, one of my professors was really nice enough to reach out to a few programs and be like, okay, there's this kid, she's extremely good, she's not going to be disappointing you, and I think she's going to make a great doctor one day. And that is all it takes. Literally, those two lines, that I think she's going to be great. Nobody has to take a guarantee over your name. Nobody has to make I got another question. Nobody has to take a guarantee. Nobody has to be like, well, this is definitely going to work out, or it's not going to bother them. It's just a good word. And once you have a good word put for you, that puts you in the forefront. So Alicia says, what you did, stalking down the residents, reminds me a lot of myself. Thank God I'm not the only one. No, you're not the only one at all. I have stalked down residents, and even from the associated colleges. So Ludhiana has CMC and DMC. That's the city I did my med school in. And I even stalked people from Tristan Medical College. I even texted them, look, I am in 5-mile radius of your college, and I'm on this journey. And I'm really, really eager to get into a residency program, and I want that for myself. Right. But that desperation should only be there till the point that you secure enough programs to decide for yourself. Because remember, you're as important as the residency program. So they're not just choosing you, you're choosing a residency program for yourself as well. You're the commodity. So don't sell yourself short at all.
Right. That was very insightful indeed. So, Dr. Kaur, emergency medicine is a very hands-on specialty, right? So, as you mentioned that you got 2 observership SLOEs on observerships, right? So, how does that work? Observerships in emergency medicine. How strong is that SLOE? Like, some people may be worrying, like when applying for electives and observerships, some EM Applications may worry that, oh my God, I'm not getting any electives, especially during the COVID times. All that was left was observerships. A lot of people graduated during that period, and all they were left were with observerships. Now, being an internal medicine aspirant, I can go for observerships because but it is less hands-on compared to emergency medicine. So, what do you have to say about that?
So while I was doing my observerships, I wasn't just observing. I would stand next to a patient being intubated, and I would be asked, okay, what do you think is the dosage that you give for etomidate? What do you think is the dosage for succinylcholine for paralyzed? What's your choice of agent? I didn't go there unprepared, and I had those answers. While performing a central line, they'd ask you questions like, oh, what do you think is the position here? What vein are you going for? Why not subclavian? Why are you going for IJ? Why not femoral? Tell us the rate of bacteremia in both of these sites. Well, how are your skills with ultrasound? So they'd show you ultrasound, and they'd be like, okay, what do you think this looks like? Does this look like a pericardial effusion? What do you think you can do in the ER for this? Can you create a pericardial window? What do you have? What are your steps for doing inserting? What are your steps for doing inserting a chest tube or performing a thoracotomy? They're going to ask you those things. It's observerships in EM are very different from observerships in IM, and you don't get a lot of them. I got my observerships. I wasn't able to be hands on those 2 rotations that I did. The SLOEs I got were not very useful. The one that was useful was the one for my hands on rotation. However, for every SLOE, you also get an LOR from an emergency medicine attending. So you have to remember that you will get an LOR and also an SLOE. So my SLOEs for those, I waived them. So I don't know how they put me up in those. But they did assess my procedural knowledge. And so SLOEs have this, it's got columns where they tell you how much percentage of procedural knowledge are you, how much do you have? This person is very good, excellent. This person's satisfactory. This person's, meh, I wouldn't hire them. So all of these are honest evaluations. And I think for those 2 programs, it was enough to see my passion, and they went ahead and added an SLOE, but it always had an observership tag to it. It didn't calculate as my evaluation form, just that. The SLOE that really helped me was for my hands-on rotation, where I got to do central line, where I got to do catheterizations and, ultrasound guided IV lines, which are very tough to get in the first go, which I did not get for the first go. And I was still scored enough points to be, that she tried. Her landmarks were correct. She knows how to perform a lumbar in the ED, and that is more than enough for us, because sometimes under pressure, you don't know those things. And if you remember them, that does give you a lot of extra points.
That's very insightful. So it's, as I thought, that emergency medicine is really hands-on. And thank you for shedding light on those points. So Dr. Kaur, can you shed some light on your experience in Masters in Health Administration?
Absolutely. My MHA, it's been quite a journey. I learned a lot about things that I did not know back in India. I'd never had classes on ethics. What is HIPAA? So we learned that, I learned that through my MHA. Quite many of my friends are still in that degree, and I made lifelong friends doing my MHA. So I always give credit to that, for that, to my MHA. But also it gave me, as I previously mentioned, it gave me a lot of networking, column. It gave me a list of people that I could reach out to for research positions. One of my professors, he's doing a QI project with me right now. I've graduated from my MHA, and I just reached out to him. I was like, well, there's this QI project that I have to do for my residency, and I know that you're probably the best person to go out to. And he's the one who's helping me with SWOT analysis and whatnot for that project. And all these things, they help you further on. I am aiming for a fellowship. I have a keen interest in toxicology. And and I hope to get there by a lot of research and other things. And MHA gives you that edge over other people. Even during my interviews, every time they asked me that, oh, well, for my interviews, how much do you know about the American healthcare system? And I could answer them correctly because I knew plenty by the time that I was interviewing. I had completed about 8 to 9 months of my master's in health administration, and I was able to give very coercive, correct answers to those questions. And everybody actually applauded my effort to do a master's in a US university, because in the end of the day, that does count. So you can't rule that out. You can't be like, oh, it's just a degree. No, you're acquiring a degree from a US university. People know what Laverne is, what California is. People do not know what DMC is here. And even though it's a hard truth, you kind of have to accept it, given that you're just transitioning to a completely different healthcare system.
Yes, yes, true. We have another. Okay. Thank you for sharing your thoughts, Dr. Kaur. I have another question. So we touched on the personal statement, we touched on LORs, and we touched on the USMLE STEP scores. What other things do you think can make a wholesome application for matching into emergency medicine? What other components?
So I believe a large part of it is your interview itself, how you project yourself to the committee, the people who are assessing you. Presently, we are holding interviews for this residency cycle. And and I can't believe that I was on the other side of the stream last year. I was on the other side of the whole scenario. And when we sit in a room and we've got like a whole list of applicants in front of us, it's a whole experience. You cannot determine a person's eligibility for a position, or their professionalism, or their ability to handle stress from their scores, or their letters of recommendation, or their SLOEs, even, because SLOEs that we've seen this year, they've been numerical. The forms that we've gotten is like, 95%, 92%. How do I differentiate a 95 and a 92%? A lot of those things come up in the interview itself. So we already, you have these questions that are just that will be asked to you, and they will demand of you to be more open about your personality, and you have to keep that in mind. So you have to present yourself as you are, because when you're working in a stressful situation like the ER room here, the emergency department, you won't have time to pretend to be nice. You won't have time to pretend to be just to be under stressful situations and react in a manner that you can just create for yourself, like a persona you think you can create. You won't get time for that. When a patient's coding in front of you, you just have to do what you have to do. And when you're being assessed by an attending who's sitting right across you from the table, most of the times when we take presentations here from patient, when we take histories from patients here, we go down to the attendings, and we don't get enough time to get all the elements out there. They already have like half a differential in their head, and you have to choose your words, and you have to be very on point with things. And that is how I would describe being an emergency medicine physician. You just have to be on point. You can't beat around the bush with your personal statements, with your LORs. The LORs that you see from EM physicians are going to be very different from what you see from IM physicians. They're not going to be talking about checking renal functions and GFR values, or she looked at them, she was determined to find the cause of whatever was going on. No. Well, she saw that the patient wasn't breathing, the patient wasn't satting normally, and she went in and she decided that she will get a nasal cannula in, put them on a blow-by, put them on a BiPAP, or go ahead and intubate. It's decision making that is assessed, and that will be assessed in your interviews. So the primary focus is that I had working for me in my application was my step score. Both my step scores, I had a step score of 255 and a 249. And anybody who tells you that your step score doesn't matter is lying to you. Do not listen to them. Your step score matters. okay, especially for a specialty like EM, where you're already at a disadvantage being an IMG. Your step score absolutely matter. You have to make sure that you nail your step exams. But yeah, if you don't, that's another perspective. We can work on it, but try your best to make sure that you're putting your 100% in that. Then your personal statement, be very straightforward. Tell them things you love about this specific specialty. You know, why you want to be an EM physician, why not IM. That's what one of the questions my PD asked me during my interview was like, well, why you he asked me why I like emergency medicine. I said, well, it's a lot of different, it's peds, it's, you know, it's, I've got old patients, it's geriatrics, I've got trauma, I've got like everything. And he goes, well, isn't family medicine the same? And I go like, well, if a patient calls their family medicine doctor in the middle of the night that I can't feel the left side of my body, they'll tell them to go to the ER. So, which is why I'm more interested in being the hands-on doctor in the ER and not being an FM doctor, even though FM is an entirely different field. But when you go to EM doctors and talk to them about that, they're going to ask you questions like this. These questions can be intrusive. They're going to feel like, okay, well, maybe they don't respect other professions as well, but they do. It's you have to remember that an independent EM room cannot function. We cannot function without our hospitalists. We cannot function without their input. We cannot function without their consults, because our knowledge base over the years, it gets limited to what we see, what we're used to seeing, and you need external input. And those things, they keep on going. So the PS, personal statement, definitely the LORs and the SLOE. Make sure that you're nailing your rotations. You have to perform. You cannot go to your rotation thinking that, oh, I'll just wake up at 6, be there 6:30, come back home at 4. No, prepare about procedures, prepare about how you can be, even if you're doing an observership in an emergency room, you can be very useful. You don't have to touch the patient. You can touch the equipment. You can make sure you're learning things. You can make sure that people are observing you learning things. And it doesn't take a lot to do that. And it's genuine effort that is going to be counting on your part. And then definitely your interview matters the most. So nail it, prepare for it. Talk to your friends, make sure you're confident, make sure you're to the point, make sure that you're not fumbling and you're prepared. That is very important.
Right. Because I'm approaching interview season and I should start preparing. Thank you for that insight. May I have one more question?
Anytime you need a friend to interview you, I'll be right here.
Absolutely, because I can take points from your proactiveness. That's really, really inspiring, I must say. And I have personally also noted that being proactive opens more doors, especially in the US healthcare system. People are very eager to help you. That is something that I've noticed, even in internal medicine. You just have to speak. You have to speak, and your manner of speaking should be right in internal medicine. Unlike, I think, emergency medicine, as you said, you have to be raw. It's okay to be raw and unfiltered. You just have to speak, and people are really ready to help you. Right? It all depends on the way you present yourself. That's true.
Absolutely, that's really true. People are eager to help you, and that can't be put into better words. You know, they're gonna go out of their way to help you out here.
Exactly.
So don't think that anybody's holding anything against you. You know, if I reach out, it's gonna be an embarrassment. What if they don't reply? If they don't reply, they don't. Let it be. But most of the times, 95% of the time, they're going to reply out to you. Reach out to them on Reddit, reach out to people on emails, look up programs, you know, reach out to them on Facebook, Instagram. Use all of these platforms to your benefit.
Right. So may I ask one more question about the application? So is doing research very necessary part of AIM application? Research, so how much importance would it hold?
Absolutely. Much. So EM is not very research heavy. It's definitely a benefit to have some research under your wing. I had one project, it was hypercalcemia induced pancreatitis, and the study was published while I was still in India, and that is the only one I had. But when you look at applications for EM, we do not look at research to a large extent. It's definitely very important for IM. it's definitely very important for FM, other specialties, but definitely not EM. Not that much. I mean, it does add value to your application if you want to stand out. Multiple research projects, they will definitely add value to your profile. But if you're not getting any projects and you're like going, putting a lot of burden on yourself that, oh my God, I'm gonna not match because I don't have two research projects. That's not true. I match with just one and I am just doing fine. So
Right. So you mean to say it's okay to not leave a column blank because it's another section of the ARRC application, but in the end, does not hold as much value as we think in other specialties. Like, for example, surgery is very research heavy.
Surgery is
Right,
very
right.
research heavy.
Yeah,
But try not leaving a column blank.
exactly.
That's what I would put it as. Try
Yeah,
not leaving a column blank. If you have no choice, then leave it blank. But don't stress yourself out over it. That, oh,
exactly.
I'm
Right.
only going to fail because my step score is 260, my step score is 270. I have great SLOEs, but I will not match because I don't have research. No, that won't be the case.
That is an excellent thought. So one more question. What are future prospects in emergency medicine? Different future prospects, and you shared your choice, it's toxicology, and I would also like you to share your reasons, what drew you towards it. First, various options, and then what drew you towards your choice.
So EM is not very fellowship heavy, but recently it's been getting very fellowship heavy. You can do a fellowship in ultrasound. Basically, so you have to remember you're jack of all trades, master of none when you're doing emergency medicine, but you have to live your life like you're master of all trades. So ultrasound is one of those leading fellowship opportunities that's going on pretty heavy right now. It's a 1-year fellowship, I believe. Toxicology, it's when you become a toxicologist. Poison control, patients with suicide attempts, somebody comes in taking, I don't know, 500 pills of Tylenol, all of those things that come under a toxicologist wing. Other things can be wilderness medicine.
I think you were muted. Sorry. Yeah, sorry.
So wilderness medicine is another one of those things. It's new, it's going great. My own program is doing a wilderness medicine fellowship and an ultrasound fellowship for our EM aspirants right now. The other one would be critical care medicine. So the one that takes the IM track is the pulmonary critical care. The one that takes the EM track is also, it's critical care medicine, but it's kind of different. You get to run traumas. You get to be on a team where you get like a very different experience. I recently had a rotation in Baltimore where I worked with a team of critical care medicine physicians who were all EM residents before this. And it was one of a kind experience. So yeah, that's definitely on my list after toxicology. I might consider that. And sports medicine is one of those things you can do. Yeah, and there's plenty other fellowship opportunities depending on what your liking is. But yeah, so they're not going to be as vast as IM. Like IM, you can reach out to GI and cardiology and all of those things. So you can't do that with EM yet.
Right. I'm seeing a question here. Hi, Doc. I love EM. I did well during my internship. Like you have shared, I asked our nurses how to do cannulation, how to take blood, how to give bowel wash. Same time, I have a red flag. I passed my step 1 on my second attempt, currently preparing for my step 2. Is it possible for someone like me to match?
Absolutely possible for you to match. Just do amazingly well on your step 2. Reach out to your seniors. Make sure that your personal statements reflecting why you have that red flag. Address it. Take it head on. Like, okay, I know my step 1 score is low. This is why it's low. This is what happened. This is why it went wrong. Okay, I have an attempt. Why do I have an attempt? Address those issues. If you just don't address them in your personal statement, they become a red flag. Otherwise, they're never a red flag. So just remember that when you're moving forward.
Right. And I believe the manner in which one addresses these red flags also matters, right? You do not have to
Absolutely.
paint yourself in a bad like or pity. Don't put yourself in a position of pity, and rather focus on how you overcame it. What do you think? Is that
Yeah, you
something like?
always have to tell them the problem, but give them the solution what you did.
Yeah.
Because
Hmm.
I had this problem and this is how I changed it. That
Hmm.
turns your red flag into a very good green flag that you're a
Yeah.
problem solver. Always make sure that you have that approach when you're moving forward with interview season or with your personal statement.
Right. There's another question, Dr. Kaur. Would you recommend going for electives before giving step exams, or is it better to go only after giving step exams?
In my opinion, it's only better to go after giving your step exams. Your
Hmm.
knowledge base is so limited before you finish your steps. In my case, I was more comfortable going for my rotations after my step exams, not before them. And I highly
Hmm.
recommend doing the same because there's a lot of information that you don't know yet. And the more you study from your first aid, you were the most case scenarios you're exposed to, the better you're going to be when you're on these rotations, and and do them with like a very short gap in between.
Mhm.
Try doing your rotations as soon as you're done with your steps.
Right. Because it's the steps that give us paint a picture about the US healthcare system, right? As an IMG, we are
Absolutely.
not, yeah, right. You're right.
Plus, if you
Thank
have your step result, you can just always be on a rotation and talk about it. That hey,
right,
this is my step result. I recently just did it, and if it's a good enough score, then you're already on your way to impress.
right. Do people is it advisable to talk openly about your step scores? If they're high, does it sound boastful or
No,
no?
no, it does.
Okay.
You worked
Because
hard for that score.
true.
Um, a person with a it's see, it can be taken both ways. Be
Hmm.
very so situational awareness is a real thing.
Yeah,
Uh, common
true.
sense is not very common. Make sure that you're only sharing it in an environment where it is okay to share it. Now, don't
Relevant.
go blurting
Mhm.
out your step score when somebody's like telling you that you did this badly. Like a nurse is coming up to you and attending is coming, well, you messed up this patient. This wasn't cool. Don't be like, oh, I have a 255 in step one. That is, of course, not going to take you anywhere and will probably
Mm.
land you back in your home country. So make sure that you have situational awareness. Talk about your step score. Don't boast about your step score.
Right,
That is always
right.
the goal.
I would like to ask, as you mentioned in the very beginning, that you were very cool and easygoing person during your medical school, and you quoted yourself as being the average scorer. And how did you, so? What was your process? What process did you choose take to prepare for the step exam? Your scores were really good, so I'm really asking for advice regarding the step exams. How to prepare for it? Timeline, if possible.
Yeah, absolutely. I think the reason why I did well on my steps was because of the underlying insecurity that I wasn't good enough to be a
Hmm.
doctor yet. And that just made me work harder to be a doctor because I've always never thought of, I've never thought of another profession. And I knew what I wanted to do from the beginning of time. And I really wanted to be good at what I do. There's no use of providing subpar care to your patients. Don't be
Hmm.
that person. uh, Study because you want to be a good doctor, you want to be a good physician. If a patient comes to you, you've got somebody's life in your hands. Do you want to be sending them away with half-hearted knowledge? No, you don't. Make sure that you know things and you're comfortable with your knowledge base while you're on this journey. That is, I
Hmm.
think, extremely important. Even when you're a resident, I come down after a 9-hour shift and I sit down for 2 hours to study. I still don't think I don't know enough. And that will keep changing over time, and it never stops. And so yeah, make sure that you're covering that. But in my med school, as you put, I wasn't studying a lot. I was only studying for my prof exams, which is not a good picture, by the way. In hindsight, I should have done better. I should have been more proactive about it, because that is where it starts, right? That is, I think, if I had been uh, more proactive about my studies back then, I would have been here a year earlier. But in the end of the day, hindsight's always 2020. And so with my step examination, the timeline, I started somewhere between my third month of internship, and I took an extension for 4 to 5 months, and I was just doing these rotations in one of the hospitals, and I was constantly studying, and not in a healthy way. But I wouldn't advocate for it. Find your balance while you're studying for your steps. And I finished what I would isn't that the now my opinion may be a little biased because I took my step in 2021, I think January. And so with time it changes. Things there may be new resources by this time, but I primarily used UWorld, first aid, so UFAP, UWorld, first aid, Pathoma, and Sketchy for microbiology. And I reviewed and reviewed till I had everything, not on my tips, I would say, but I was conceptually very confident going in. And I because it's a very long exam, if you go in thinking that I will learn everything, that is not going to take you anywhere. You have to make sure that you have the foundation clear. You have to make sure that you know all the concepts before you walk in there to handle questions based on that. So that is where I think it comes in. Also, don't delay studying for your steps. Study whenever you can.
Right. That was really insightful. Dr. Kaur, can you shed light on one more thing? Because another problem that IMGs usually face, is the timeline for step exams. The entire USMLE journey is so long that a lot of people start losing faith along the way because it is so long and tedious. You see your colleagues getting matched, starting residency, entering PGY1, PGY2 in their home countries, while you are still sitting, and studying for step exams. And this is especially scary for people who started an internship. My own friends keep asking me, like, if I begin it now, it will take so long. How can I bear with it? Can you please shed some light on that?
With the timeline, I think that is very subjective to the person who's doing it. My chief resident here in my very own program is an IMG. He's already completed his emergency medicine residency in United Kingdom, and then he took his steps and he came down here. And I asked him the same question. I was like, do you feel like you're doing too many residencies? You could have been like an attendant. And he wasn't attending, he was a medical director back there. And he says, well, it's subjective. I really wanted to do this and I got it done, and that is all that matters. So even though it feels like there's people crossing over in their intern years, but never compare your profile to somebody else's. Your journey is your own. Do not be comparing it to other people. Take your time doing things. Now, don't take too much time. Don't take years taking your step exams. That is never advice. But don't compare your journey with somebody and rush it, thinking that you're going to be, you need to be there sooner, because the end destination is the same. And if you put in enough effort, you'll get there just in time.
Right. So Dr. Kaur, there's another question. Does scores in 230s filter you out of emergency medicine?
So no, it won't. Always when you're applying to a program, make sure that you go to the website and you see their cutoff score. That is very important. Sometimes we end up applying to programs with cutoffs, and most of these programs have filters in place. And if there's a filter in place for a step score, they probably won't receive your application, and that's $26 wasted. Don't do that to yourself. Always go to the program's website, do your research. That is why they say that when you're in the application cycle, your application cycle starts 4 months in advance. That is when you should start doing your research individually. Go to every program, that this is where I might go. Look at the IMGs, see their step score, see their visa status, if they sponsor or not, and only apply to programs that are in your window. So don't set hope on something that will not even be, they won't even be looking at your application there.
Right. Another question is, Dr. Kaur, now that step 1 is just pass fail, what effect do you think it will have? How the applicants will have to change their approach? I think the focus will be more on the content of the CV now, right? Or step 2 scores?
Step 2 score.
Right.
You still have a numerical step 2 score, and that will add advantage to your CV. But your CV is very, very important. It's
Mm-hmm.
extremely important to have a good CV, because even if you pass a filter with good step scores, or you're in there, and they look at your profile and they're like, well, this person is bland, it's not going to work for our team, they will not take you. Make sure that your CV is standing out. Put in things you love, reach out for experience. So all of this comes down to networking and reaching out to people who are willing to help you. Even in my very own program, I've got two of my friends coming in for doing a rotation. It takes nothing. It took me nothing. I just went to the program coordinator and I told them that, I've got uh, two of my juniors and they wanted to do a rotation and they're coming in. And they were kind enough to be like, okay, well, that is great. We love to have students come in, observe, and do observerships, and they allow them to come in and do those observerships. So have somebody vouching for you, reach out. I think networking is the end game. And somebody posted a question about MHA. I did my MHA, half of it was online, the other half was in person, and most of the contacts that I made was during my time at the campus, and it was extremely useful. So I would just put it that way.
Right. Right. That answers the question how to make contacts. It's contacts cannot be made in the US while sitting in India, right?
So
Right.
contacts, you won't be making contacts from India. You already have contacts in India. Your medical college has had generations and generations of
Right.
IMGs going out. Every batch at least has 3 to 4 people applying to USMLE, applying for the match. Most of them match somewhere, and reach out to them. So you're not reaching out to people in the US. That is your people who are here. Reach
Right.
out to your people
Right.
who are here. They will help you. And once you're here, you reach out to more people.
Right. That's just something that I found, I personally felt, because I was trying to network and it only happened through my alumni. I had to go back like 10 years to find out an alumni, and right now they're helping me with my interview process. And it's in the end, it's your people that help you. You're 100% right. So there's a question in the chat box which says, so I would like to say that Dr. Kaur has done her MHA from University of La Verne, California. What should one do from scratch to do MHA? Hardly know about it. There's a comment. We talked about it, right?
Yeah, for your MHA, you need to be looking into universities that you want to apply in. Google is your best friend. Look for universities that have health administration and they're open to students who are international, and look at their curriculum. Make sure that they're inclusive for physicians. Make sure that they've got classes that are useful to you in the end of the day. A lot of this content is going to come in very handy when you come into your residency and you're like, being a part of committees, and you've got to have a QI project under your wing, you've got to do some research under your wing. So it'll come in very handy. But definitely look up MHA programs. I did my MHA from University of La Verne. And I found out about it through one of my friends who was already doing his MHA from University of La Verne. And I talked to him about it. I was like, well, I think I need MPH, or I need some sort of extra feather in my hat, because I feel like I'm still not good enough. And he told me that he was doing his MHA from University of La Verne, and I filled in an application. It was a $25 application fee, and I hoped that it'll all work out. And I reached out to another one of his contacts who was already in the university, and they looked out for my application, and it was a very easy peasy process. For University of La Verne, they do not have, I think there's the entrance test for MHA that you have to take. The name's not on top of my head right now, but they do not have a requirement for that. GRE, I guess, something like that. I don't think they have like a requirement for that test. They transitioned my credits for MBBS into my credits for MHA and the entrance test that was required, and that really helped me get into it. And it was, and there's multiple universities offering these programs. You look it up once and you will start getting emails about universities offering MHA. It's
Yeah.
how Google works.
Yes, and you, as you had mentioned before, your MHA experience on campus helped you build a lot of contacts, and those contacts came always come in handy one way or another, right? And in-person interactions, they come up in little ways, right? In your journey later on, because somebody just asked, did doing MHA help building your CV, and which you have already touched on.
Oh yeah, absolutely. It helped
Yeah,
me immensely.
yeah.
I'm very thankful to my faculty from University of Laverne. They were very kind and they were very generous with my whole process. They knew that residency process itself was very, because most of them
Hmm.
are medical directors from these places. They're working with the GME committee and they're working with these program managers and program coordinators, and they know how the process works. So
Right.
when I reached out to them that I was already up in the cycle, and they were like, well, you've got plenty on your plate, so just take it slow.
Right.
And they were very accommodating with my journey.
Hmm. Uh, thank you for shedding light on that, Dr. Kaur. May I ask you, one of my last questions, because a lot of my questions have been answered. I request the attendees to ask more questions, post them in the chat box. Until then, Dr. Kaur, I would request you to shed some light on the Akal aid.
Oh yeah,
Yeah,
sure.
yeah, please. The entire.
So Khalid is one of the reasons I'm halfway in US. It's been founded from my very own house. I'm basically, my family, half of my family is in Michigan, and my uncle's been into social work for a very long time. And Akal Aid was built because of this. When there was the farmers' protest was at its peak, and I'm a Sikh, and I think a lot of my strength comes from being a Punjabi. Because after a hard day at work, I come down and I pray to Babaji and I put on Rera Sahib, and I'm calm, and I achieve some
Hmm.
amount of peace, and it keeps my chakras clean and all of that. So we're very spiritual. My entire family is very spiritual, and we're farmers back in India. My family owns land, and we've been farming for a lot of years. And Akal Aid was basically founded to help that particular journey for our farmers, for the Punjab revolution that was going on. But as we've gone forward, it's allowed us to help families in need. Presently, we have an active group where there's people like me who've just started working in the US. Even $50 in your US currency can make a difference to somebody back home. It can take them from having no food to getting groceries for like a whole month. And once you start putting that into perspective, you're willing to do a lot more. And it comprises of older people and younger people. There's a whole generation behind it. And it became an idea while we were just it was just me and my uncle, and we were having our morning tea, looking we were looking at the news, this news channel. I think it was BBC News. It was talking about the farmers protest, and at that time Indian news channels had this whole propaganda thing going on, so we wouldn't listen to any of that, and we were listening to BBC News. And he goes, being away from home, I've never felt more close to home. Like, I've never felt closer to home, and I want to do something to make sure that remains. And I'm like, I absolutely agree. We need to do something to make sure that if this goes forward, we put some input in it. And it started with 5 or 6 families. By God's grace, right now it's pretty expanded. We send help back to India, we send them monetary help. We send them food, whatever we can, in whatever way we can afford. And it's been going on for around 2 years now, I think 1.5 year. Yeah.
That is beautiful, Dr. Kaur. Indeed, that is very beautiful. Thank you for sharing your experience. So there's another question in the chat box which says, when should the step 3 be taken to be applicable to this math season?
You don't have to take
Yeah.
step 3 to be applicable to this
Hmm.
math season. You can take step 3 at your pace. You just need step 1 and step 2. If you want to give an extra edge to your application, you can take step 3, but I don't advise on it. Take step 2, take some time to relax and unwind, because residency itself is going to be very hard. There are days when you will come back questioning everything, and you don't need to put yourself through the burden of taking step 3, taking all of that to get into residency, because once you're here, there's a lot more to education. That's more the books won't prepare you for it, if that's what you're looking for. Like, if you're taking it just because you want to be more prepared for residency, I don't see a use to it. Just today, I think it was probably the hardest day for me at work, and I came out of my ER questioning why I'm doing it. And my lead pharmacist, he comes to me, he's like, Ramandeep, do you feel like you shouldn't have been an EM physician today? And I told him, I was like, well, today's the day I feel like I should have been a better EM physician. It's not that I want to leave it, I just want to be better at it, because if there was anything else that I could have done for that patient in that moment, I should have, but it was not one of those salvageable situations. So step 3 is not going to prepare you for that. Take step 3 in your own time. You don't need it for math season.
Right. Thank you, Dr. Kaur, for sharing that. There's another question in the chat. Is EM as an IMG, how IMG friendly is EM compared to internal medicine, psychiatry, neurology, those branches? Can we consider it like an IMG friendly program in general?
No, EM is not very IMG friendly because of the reasons that we've addressed throughout.
Yeah.
But that doesn't mean that it's not achievable.
Yeah.
If I can do it, literally anybody can do it. So, if you make sure that your application is standing out and you make it a point to get into, see, if you have an EM track mind, none of those specialties will please you in life.
Right.
If you have an EM mind, no matter how long it takes, you'll make sure that your application only goes to EM, and that is the only place that you get in, because IM won't please you, psych won't please you, you won't wake up happy in neuro. You have to keep that in mind. And as I said previously, as much as you want EM, as much as you want a residency program, they want you the same amount. So make sure that you choose what you love, and not just because EM makes more money or this is like that or something like that. There's no point in that. Make sure that you're choosing things that you'll be happy with moving forward. EM has a very high burnout rate. And you have to know that when you're going in, because on everyday basis, you see so much trauma that it keeps on piling up. And most of the physicians, they start retiring after 55 years of age, because it's been that way for generations now. So it's not IMG friendly, but you can make it friendly to you, and just make sure that you are program friendly. And as much as you work on your CV, EM will be more accepting of you.
Right. Thank you, Dr. Kaur, for sharing that. Another thing that I want to ask is the visa debate. Are there enough EM programs that offer H1 sponsor H1B visa? And if they do, should we prefer H1 over J1, or is it vice versa? I mean, the choice between the debate between the visa. One has the burden of waiver, but is actually increases the prospects of fellowship, etc. The other one does not have waiver, but severely reduces our chances of fellowship. How do you think we should make that call?
So definitely you have to know that the J1 versus H1 debate is a personal choice. And in the end of the day, there's a lot more IM programs than EM programs. Even though EM programs are, the graph is going up, they're substantially increasing in number. But EM programs, as they're increasing, the number of visa sponsoring programs is also increasing. But you have to remember that if you go for H1 over J1, that decreases your chances of matching to an extent. Because for a program to sponsor H1, now I don't know the scheme behind it or however the calculation works, but H1 is much harder for programs to, give out. Whereas J1 is, I think, ECFMG sponsored, so it becomes like easier for them to acquire. And if you apply as a J1 applicant, you will have a lot more options, and you'll be able to apply in more programs. For H1, you'll severely limit your options. That is the only way I'll put it. And there's no need for an H1 when you can have a J1, and it's complete residency first, is my opinion.
Right.
And then you can decide where you want to go from there.
Correct, Dr. Kaur. Yes. So Dr. Kaur, our session is coming close to an end. So could you please share some contact where they can reach out to you?
Yeah, absolutely. I think I sent out my email address, but okay, I'm going to try not sending this to a direct message and everybody, but my tele skills are, I'm not very smart in informatics, but so it's ramandeep4514@gmail.com. That's my personal email address. Please reach out to me for any questions that you might have regarding the specialty, regarding visa requiring programs, regarding anything you need help reaching out to a colleague or a person who can help you in your journey. I'm here to help. I'll do what I can in my power.
I have two questions, Dr. Kaur. The first one is, like you just mentioned that a lot of EM doctors tend to retire in at around age 55 or something. So this is another thing I have heard about emergency medicine, that it is hard to continue over a prolonged period of time, because it's really exciting, and because initially you're young, you're full of energy. So emergency medicine comes with a personality. If you have a personality that goes along, it comes naturally to you. But over the years, continuing the same, working in the same stress and emergency kind of state can lead to a lot of burnout, and a lot of people, as you said, retire at an early age. So do you think is that a drawback about emergency medicine?
It definitely is. It is a drawback. So you have to remember that when you're applying. As I previously put, personality really matters here. You cannot be an EM physician if you're not ready to fight loss every day and wins every day. You need to celebrate your little wins, and you need to cry out your losses. Just today, I had like a very bad case where, and the thing is, you see a bad case. This was probably my first one. I'm in my I'm early on in my residency. I'm in my PGY1. And I had a 2-year-old with a gunshot wound to his right eye. It was a penetrating wound straight through his brain, where I could see inside his skull. And there was no way I could save that baby. But it was that scenario where I had to be put in that room with him. I had to secure his airway. I had to get IV access. I had to give him blood. I had to make sure that I was keeping his vitals stable. If that happens to me, imagine that happening to you, not every day, once a month, for 55 years. Would you be able to continue?
That's hard.
Would you be done with your life choices? You would be. So it is very natural for emergency medicine physicians to have a high burnout rate, because we see so much tragedy that doesn't even reach the floors. It doesn't even reach the hospitalist. They don't even hear about the case. In my very first week, I had a patient, full code. He came in with a ventricular bleed so bad, with a midline shift of 2.5 centimeters. What could you do in that case scenario, other than paging neurosurgery, securing airway, and making sure that they live at least an hour so that the family can have some time with them? And then you go in and you call time of death, and that is it. you were still a doctor. You did your best in that situation with whatever you
Right.
had. Imagine having that loss for a long period of time. So there's a lot of joy. I get to discharge so many happy babies. I get to discharge so many people with UTI, and I'm very happy doing that. It's my
Right.
little wins. And sometimes I diagnose a subdural hematoma just in time for it to be drained and the patient to be going back home in a perfectly stable condition, and that makes me very happy. Those are wins. But when you have such heavy losses just overpowering your entire journey, I think it's very natural to be burned out by 55 years of
Right.
age, and I don't blame anybody for it. But it's a part of EM. So when you come in deciding to be an EM physician, you have to be ready to embrace all of it. You cannot come in underprepared for it, because if you don't have thick skin for this profession, you won't make it. You'll probably be out in the second week of residency, because you're going to see so many cases,
Right.
so much volume, different acuity every day, that you're probably going to run for the door in the second week if you're not ready for it. So only choose EM if your personality can handle it. That is
Right.
why we keep focusing on personality in this.
True. True. I have two more questions, Dr. Kaur, that led to.
All the time.
uh,
So
the
I'm done
first
with my
one
show.
is okay. So the as we said, it leads to a lot of burnout, and a lot of physicians tend to retire at an early age. So can you share something? What do they usually go for after that? After they retire, like 55 is still early to for retirement. And the second question I wanted to ask is. As you said, you deal with sometimes you deal with a degree of trauma that doesn't even reach the upper floors that you have to deal it. So a lot you're put in a lot of situations where you have to deliver a lot of bad news, sad news to the family. What is your approach to that, and how do you like? It is a very heavy thing. In the end, we are human beings, right? If you're a doctor, you're a human being. How does it affect you when you go back home? How do you detach yourself from it? These are the two questions I have to ask.
So for post 55 years of age, I can talk about myself. I plan on not doing so many shifts.
Mm-hmm.
I plan on reducing the number of shifts I put in for and the hours that I put in. I plan on reaching into a faculty position where I can teach instead of practice.
Hmm.
And all these options are on the table. You can be a
Hmm.
program director while you're not practicing clinically.
Hmm.
There's other things. And plus since I have my MHA on board, I can be a part of the executive committee. There's so many things you can do in the GME,
Hmm.
having that higher education. And you don't have to get your MHA prior or MPH prior to your residency. You can sometimes we our present residency program for our chiefs, it's they're willing to sponsor MHAs posted that we
Hmm.
want our physicians to be trained in the accounting side of things and all of that. So a lot of programs do that for their physicians, so you don't have to exactly run into everything, and you don't have to
Hmm.
have everything figured out when you're going into residency. But yeah,
Hmm.
that's my plan, to not do too many shifts and teach. I love teaching.
Yeah.
I love speaking out for things that matter to me, and I love the learning curve that knowledge brings me. I absolutely enjoy it. For the second question, I believe what you need to have is detachment skills.
Hmm.
Uh, so delivering bad news is never easy on a physician. I don't think it'll ever get easier for any physician at all. You just go in, not complicate it, tell them you did your best, but it was there was nothing more we could do, and this was their time of death. You have all the time you need with your person there, and you pray with them. Just today when I went in this case, I prayed with my patient's family for 2 minutes, and I prayed to Vaiguruji, I prayed to
Mm-hmm.
Guru Nanak Dev Ji for their soul to receive peace, and I did that in my language. I don't have to. I stood there and I held them in their grief. I hugged them
Hmm.
and I said my goodbye, and I let them take their time with the patient. Um,
Hmm.
but when it and it will stay with you throughout his
Hmm.
shift. You come home, you pray for them again, and you pray for yourself. and you kind of learn to live with it at one point, but it never gets easy delivering sad news. But you need to have detachment skills. You need to make sure that your mental health is not suffering in the middle of somebody else's loss. It's definitely your loss. You lost a patient, but they lost a family member. So you have to differentiate between both of those things. You can't give less to your family or your loved ones because you're experiencing loss from somebody else. So having healthy boundaries, come back home, relax. I took a nice shower. I was there. I talked to my family. I talked to my friends back home. I called one of my best friends, and I talked to her, and I cried. I cried for like good 10 minutes. And she's, Raman, are you okay? What is going on? I'm like, I've been and my patient passed away at like 9 a.m. All day I've been working. All day I've had this strong front. I've gone through, I've delivered excellent patient care to my other patients. But that doesn't mean I don't get to rehumanize myself. I don't have to be not human to be a doctor.
Right.
I came back home, I sat in my car and I called her and I cried. I was like, well, this happened. And I was just so sad. She's like, are you okay now? I'm like, yes, I'm perfectly fine. I get to vent to you. I'm just fine. I'm doing okay now. And I come back home, I speak to my family, talk to my loved ones, and I feel better. Everybody has to have their own way of rehumanizing. I think that's very important. And that's one of the first things you learn in emergency medicine, in your very orientation sessions, that you're going to be facing a lot of loss, but you need to have a skill set to rehumanize.
Right. That was really insightful, Dr. Kaur. Thank you for sharing. So we will end this session with a quote from you. What is a quote or a few quotes that you live by that you would love to share? Because I'm definitely going to get this on a t-shirt. See one, do one, teach one. This is one thing that I'm going to learn from the session. Are there any other life quote or quotes that you live by that you would love to share? I'm ready with my pen.
The one that I actually live by is hard work beats talent. So if I lived around toppers all my life, but then I worked really hard and I got to a point where I am a topper. So I'm fine with that. So hard work beats talent. Always remember that. And see one, do one, teach one.
Yeah, I'm getting the little t-shirt. Thank you so much. Thank you so much, Dr. Kaur. This last call, does anyone have any more questions? Yeah. Any more questions, or we can end the session now because it's time. If you have any more questions, please reach out to Dr. Kaur or reach out to me, and I will connect you. I'll just enter my email. If you have any queries about this session, please reach out to Dr. Kaur or Dr. Me. Thank you for coming, Dr. Kaur. It was wonderful chatting with you. Very insightful.
It was great talking to you, Esha. You're a great host. Thank you so much for having me. It's extremely nice. It's an honor in the end of the day.